Dr. Rohit from the panel. He is moving to the podium. He's talking on a case of recalcitrant fungal keratitis.
Okay, good morning all. Thank you AS committee for giving me this opportunity. No financial disclosure. I will not bore you with this. So this is a case of 55-year-old female who was symptomatic for 25 days. She gave just a vague history of that something has fallen in the eye 25 days ago. And the outside physician has prescribed natamycin and moxifloxacin, which she was using hourly. So vision in the right eye is HM plus, and this is the right eye status. You can see the nasal half of the cornea is having a deep stromal infiltrate, and there is a hyperpion of 2.5, and if you see the arrow, there is a bulle. And this is the set picture which can show that infiltrate is mainly located into the deep stroma. And on the fluorescent stain picture, there is no epithelial defect. Now what will you do? So I planned, and this is the B scan, which is absolutely normal. So we suspected is clinically fungal, and we planned for endoscraping. And if the something comes on the smears, then inject antifungal intracamerally. So day one endoscraping, nothing came. We started on routine. We don't start empirical antifungal. If there is no fungus, we just give fortified antibiotics, Ciplox and cefazolin. Day 7, she worsened. There is a more than half chamber hypopion. B scan is absolutely normal. So I still thought that we should find out the organism. We again did the endoscrape, and again I repeated the scraping. Again I sent the exudates for the microbiology. Nothing, no organism. So the day 14, fourth visit. So that visit, I thought now there are two options: whether you do biopsy or you take the patient for therapeutic PK. So at this visit, I decided, okay, I will do therapeutic PK and will do intracorneal back scraping, from which we can I reach the deeper part where the exudates were locating with the back scraping. So these were the donor details. 71-year tissue preserved in MK. It was used, and the operatively we find out that the graft infiltrate was pretty much large. It was not very 10 to 10 mm, and we took 11.5 mm graft. Again intraops corneal scraping, negative. Again I send the intraop exudate, that also negative. This is the post of day 1. So now we have done a therapeutic PK in an MK patient. We don't know the etiology. So post operative, whether we will start steroid or not, it's a question. So what you can do is you don't start steroid on day 1. Just wait for 2-3 days. Check for the histopathology or check for the half corneal button. So I waited for 2 days, and second day the half corneal button showed fungus. So I added antifungal in the form of natamycin and oral ketoconazole. And this is the day 14 picture. There is no recurrence, no residual of fungus infection. So at day 14, I added the steroids, not 1 hourly, still because it was a large graft. Not sure that it can recurrence can happen again. So 6 times I added, and the half CB showed Fusarium saloni. And by the time histopathology report has also come, and it has shown that fungal filament. So this was the pre-op course. Multiple AC wash, multiple endoscraping, 4 scraping, 2 endoscraping, 3 corneal scraping, 3 times AC wash. Nothing came. And this is the post-operative course. Patient at 6 months doing well, 20/100, waiting for the cataract surgery. Learning points: always try to find the etiological organism which is causing the keratitis. Don't start empirical antifungal treatment. Don't wait too much if the patient is worsening. Like after 2 weeks, I planned for therapeutic PK. And in case where you don't know the etiology before doing surgery, histopath and half corneal button will guide you the what the post-op treatment you will start. Thank you.
Thank you, Dr. Rohit. These are the frustrating cases and well documented. I agree with you that maybe early diagnosis would have helped. Maybe in your initial, when you did your AC tap, also a corneal biopsy at that point would have helped. But ultimately, sometimes these deep stromal infiltrates do not respond, and therapeutic PK is the only answer. Only point I had to make is probably I would wait for at least 2 weeks or wait for the culture report before starting steroids. If I'm
I started after 2 weeks only.
2 weeks. Okay, I thought you said 2 days.
No, 2 weeks.
2 weeks is
The
great.
second day, half corneal button showed fungus. I waited for 2 weeks.
2 weeks.
After 2 weeks
All right,
only.
yeah, okay. So yeah, it's a great, well managed case. But early, maybe in the initial AC tab, do you think a corneal biopsy at that point? Would
I
have
was
been
waiting
more
for 1 or 2 weeks. So at 2 weeks,
yeah, because anyways you're taken the patient up in the operating room. A corneal biopsy at that point would have given you a diagnosis, and then an intrastromal probably voriconazole injection would have also.
I don't give like empirical.
Not
if I,
empirical. If the corneal biopsy
yeah,
would
if
have
it
shown
shows
you,
fungus, then yeah.
then an
Yeah.
intrastromal also takes care of these
Yes.
deep infiltrates, and then you can end up with a nice scar and eventually plan a
Yeah.
PK later. But yeah, well managed case.
Thank you.